Hi guys, today I will discuss about paraplegia, that is weakness in both lower limb. First of all, I'll discuss about upper motor neuron paraplegia, causes of which are in six categories: tumor, trauma, infection, infarction, degeneration, demyelination. So it is very easy to remember: two T's, then two I's, and then two D's. Now, tumor, it can be primary spinal cord tumor or it can be secondary tumor. Usually in males, tumor come from prostate, while in females, tumor come from breast. These are metastatic deposits in the spinal cord. Then trauma, any sort of trauma which occur directly on the spinal cord or by lifting some heavy weight and causing disc prolapse can lead to upper motor neuron paraplegia below the level of spinal cord compression. Then infection. Tuberculosis infection is the most common infection in our area, and this is called also Pott's disease, which is the tuberculosis of vertebral column. And infarction, it is just like the infarction of the heart or that of the brain. Interior spinal artery, it gets occluded by thromboembolism, and it is because of atherosclerosis, and the risk factors for subacute spinal cord infarction are the same as that of coronary infarction or cerebral infarction, that is hypertension, family history of dyslipidemias or hyperlipidemias, diabetes mellitus, smoking, and all these things. Then degenerative spinal cord disease means that osteoarthritis of the vertebral column, and these osteophytes then they cause compression, and if this compression is severe, it can lead to spinal cord compression. Otherwise, it leads to different sort of neuropathies. Then demyelination, multiple sclerosis is another reason in which the spinal cord, it can be affected and it can produce upper motor neuron paraplegia. So these were the causes of upper motor neuron paraplegia. Now we will discuss what are the features of upper motor neuron paraplegia. Usually we get weakness, but this weakness is associated with spasticity, and there is hypertonia, hyperreflexia, and plantars, they are upgoing. If spinal cord is compressed, then we may get a sensory level. And how do we check sensory level? Usually sensations on the forehead of even a quadriplegic patient, they are intact, because quadriplegia, it can occur if cervical cord is compressed, and since forehead is above that level, so sensations over forehead, they are normal. So we compare sensation of the forehead with the sensations of the feet. Usually in a patient with spinal cord compression, the sensations of the feet, they are less as compared to that of forehead. So we continue to touch lower limbs above or in ascending fashion until the sensations on the body, they are similar to that of the forehead. That level is approximately the level where spinal cord is compressed. So by this we get an idea that which part of the spinal cord should be scanned. So investigations are MRI of spine and nerve conduction studies and EMG to see if there is any lower motor neuron cause like neuropathy or myopathy. So these both tests, they are the main investigation which we do in case of paraplegia, and some other investigations can also be done to support the diagnosis, like CSF analysis, in which we see protein cell pleocytosis in some patients of GPS or oligoclonal bands in case of multiple sclerosis, and X-rays of vertebral column 2 to see any disc prolapse. Then comes lower motor neuron paraplegia, and there are three categories, main categories, which can cause lower motor neuron paraplegia, including neuropathy, myopathy, and neuromuscular junction problems. Neuropathy, it can be acute demyelinating neuropathy like GBS, or it can be CIDP. Myopathy, it can be inherited myopathy, or it can be by any drug like statins or steroids, or it can be because of any disease like Cushing syndrome, and then neuromuscular junction like myasthenia gravis. So the features of lower motor neuron paraplegia are weakness, hypotonia, hyporeflexia, and downgoing plantars. Investigation we have already discussed, and after that comes the treatment. If it is upper motor neuron paraplegia and we are suspecting spinal cord compression, then immediate decompressive surgery is the solution. And while we are waiting for this decompressive surgery, we can start with IV steroids. And if we are suspecting that this is any infection like tuberculosis, then we can give antituberculous therapy. And if there is any collection of pus or abscess, cold abscess, then that can be drained. And similarly, if it is because of any demyelination, again IV steroids or immunomodulators they are given. And in case of neuropathies, we can give a patient immunoglobulins or plasma pheresis. So the treatment, it depends upon the cause of paraplegia. Then a third category of paraplegia in which we get both upper and lower motor neurons signs. For example, we get absent ankle jerk and upgoing planters, and usually the causes of this mixed sort of paraplegia are subacute combined degeneration of spinal cord, in which there is a degeneration of lateral corticospinal tract, spinocerebellar tract, and dorsal column tracts. Then we have got Friedreich's ataxia, which is a degenerative disorder, and again here we get cerebellar features, and along with the cerebellar features we also get kyphoscoliosis, or we can also get optic atrophy or optic neuritis, Hawcom, then bilateral Pascavus. All these things, they are present in Friedreich's ataxia. Then we have got motor neuron disease, especially amyotrophic lateral sclerosis. Variety of motor neuron disease has got mixed feature of upper and lower motor neuron signs. Tabes dorsalis is actually a type of syphilis in which we got dorsal column loss. So position sense is lost and there is ataxia. So the treatment, it depends upon the underlying cause along with supportive therapy. If it is tuberculous spine, then we give ATT. If it is neuropathy, that is acute inflammatory demyelinating neuropathy, then we can give plasmapheresis or immunoglobulins. If it is multiple sclerosis or transverse myelitis, then again we have to give IV steroids and immunomodulators. And if we are suspecting compression of spinal cord, the immediate treatment is decompression of the spinal cord.